Today our topic of discussion is a demyelinating disease. So first we discuss the myelination and the cells of the myelination. So the myelination in CNS take place through the oligodendrocytes, while in peripheral nervous system it is due to Schwann cells. So these Schwann cells are derived from neural crust. So they are derived from neural crust, while oligodendrocytes are derived from neuroectoderm. So oligodendrocytes are derived from the neuroectoderm, right? So what are the function of the myelination? So what is the function of the myelination? So myelination increase the conduction velocity. So it increase the conduction velocity. So what is the formula of the velocity in physics? Velocity is equal to length divided by time. So, so myelination decreases the time constant. This is again a high yield point. So myelination decreases the time constant and it increases the length or space constant, right? Velocity is in physics point of view, the velocity is equal to the length divided by the time. So if you increase the myelination, then it will increase the length at p constant. It will increase the conduction velocity, right? So one more thing. So it will increase the membrane resistance as well. How it will increase the membrane resistance? Look at the picture. Let's suppose this is a Schwann cell. What does Schwann cells do? They myelinate the peripheral nervous system neurons. So this is a myelination. So, so they myelinate, it will do the insulation. So this portion is the insulated portion. Here is a high resistance, but this portion has a less resistance. These are the nodes of Renevers. The nodes of Renevers, so the nerve impulse or conduction only takes place through these nodes of Renevers. So through these of nodes. In this way, this conduction is also known as saltatory conduction, and it will increase the conduction velocity, right? So the myelination increase the membrane resistance. So myelination, again, this is again a important stuff. I'm going to change the color of my cursor just in the another color. Okay, so it will increase the resistance, and while decrease capacitance. These are some fancy words you found in the question. Space constant, time constant. So these are the some simple stuff. Increase the conduction velocity, right? So you have to know, keep in mind these things. Okay. So the Schwann cells are injured. These cells are injured in which disease, which demyelinating disease? GBS. Guillain-Barré Syndrome. There's so many pronunciation of this syndrome. So Guillain-Barré Syndrome or GBS. So what is the marker of the Schwann cell is S100, right? Okay. So each Schwann cell, you noted that it myelinate only the one axon. So this Schwann cells myelinate only one axon. While the oligodendrocytes, it myelinate many axons and up to 30. Look at that. This is the oligodendrocyte. So what does do? It myelinate. This is another axon. This is another axon. So oligodendrocyte myelinate many axons, right? So it may up to 30 axons, right? And it's derived from neuroectoderm, right? So this Schwann cells for the peripheral nervous system and this oligodendrocyte for central nervous system. So another high yield exception that the cranial nerve 2 is myelinated by oligodendrocytes. Cranial nerve 2 is myelinated by oligodendrocytes, while the other cranial nerves are myelinated by Schwann cells, other cranial nerves. It makes some sense. Are you with me, guys? Okay, let's move towards the demyelinating disorder. Okay, so demyelinating disorders are simply classified into three types. So some book says that ALS also considered in the demyelinating disorders, right? So these are the some high yield demyelinating disease a for the USMLE Step 1. Okay, so first is MS. MS is multiple sclerosis. So can anybody tell which cells are damaged in the multiple sclerosis? Which cells? Schwann cells are oligodendrocytes.
Oligodendrocyte.
Okay, so oligodendrocytes. Okay, what about the GBS? Schwann cell,
Schwann cell.
right? And what about the ALS? ALS is what is the ALS? Can anybody tell me the full name of the ALS? Amyotrophic lateral sclerosis, right? So it is a amyotrophic lateral sclerosis, right? So it is a combination. It is a combination of upper motor plus lower motor neuron disorder, right? But okay, let's move toward the multiple sclerosis. So multiple sclerosis patients typically there are multiple neurological complaints. So there is a multiple neurological complaint, multiple neurologic complaints. That complaints are not simply explained by the single lesion, right? That complaint are not simply explained by the single lesion and that are separate in a time. Okay, so the multiple sclerosis patient typically present with a triad. So can anybody name that triad? It is a Charcot triad. Charcot triad. So this Charcot triad is consist of three things. that are a scanning speech, intranuclear ophthalmoplegia, and nystagmus. So intranuclear ophthalmoplegia is due to the damage of the medial longitudinal fasciculus. Medial longitudinal fasciculus, right? So the Charcot triad. So the course of the GBS is relapsing and remitting history. So the main course of the multiple sclerosis is relapsing and re-emitting. It better spontaneously. Sorry. Okay. So multiple sclerosis, it's a multiple neurological complaints that are separate in a time and space and are not explained by single lesion. Okay. So relapsing and remitting is a course of the multiple sclerosis. It will present with the mainly the scanning speech, intranuclear ophthalmoplegia, nystagmus, right? It may present with the urinary retention, sexual and other problem as well. Okay. So what are the best diagnostic investigation for the multiple sclerosis? So the diagnostic investigation is MRI. What you find on the MRI on multiple sclerosis, MRI you found multiple asymmetric paraventricular plaques. You found the paraventricular plaque as well, particularly in the corpus callosum, right? You may found the oligoclonal band in the CSF, right? So oligoclonal bands on the CSF and the MRI, the paraventricular plaques. Okay, so the treatment is again a very, very high yield. So multiple sclerosis treatment is a high yield stuff. So, so it is divided into two things. Multiple sclerosis, acute exacerbation and prevent the further episodes. So acute case, acute exacerbation, what will be the drug of choice? An acute exacerbation, high yield stuff. Can anybody know acute exacerbation? So it's a steroid. It's a steroid. So this is a steroid, mainly IV steroid. And what about the to prevent the further episodes? We use immunomodulators, right? Interferons, prevent further episodes. We use immunomodulators, right? Interferon, right? Okay. So the sympathetic treatment as well for the multiple sclerosis. If the spasticity, what we use, drugs that relieve the spasticity if the patient present with the urinary problems, we will treat these things according to the symptoms. But the main high yield stuff, acute exacerbation, the steroid, right? So this is some review about the multiple sclerosis. Let's move toward the GBS. Okay, so the GBS. It's the autoimmune disorder. Again, which cells are damaged? It's the Schwann cells are damaged. So it's a high yield association with some bugs, and most high yield is Campylobacter jejuni. So the Campylobacter jejuni is a high yield association. Campylobacter jejuni. So it is a bacteria. Okay. So some other viruses as well, but the most high yield is a Campylobacter jejuni. That is uh, uh, bacteria. Okay. So another name of the GBS is acute inflammatory demyelinating polyneuropathy. Okay. So the typical presentation. Okay, wait. Who is adamant? So what is a typical presentation? What is a typical presentation? The typical presentation of GBS is simple, symmetric, ascending muscle weakness. Symmetric, ascending muscle weakness. So symmetric, ascending muscle weakness. Right? So it's a basically endoneural. Sometimes they ask about the GBS is a endoneural inflammation with segmental demyelination. Endoneural inflammation with segmental demyelination. So this is again the high yield point. What kind of myelination? Segmental demyelination. Okay, so again one more thing, one more high yield stuff. So there is a no role of the steroid. There is a no role of the steroid in the GBS, right? And the exam want to confuse you. The steroid has a role in multiple sclerosis, but there is a no role of steroid in GBS. There is no role of steroid. There is no role of steroid. Okay. So, so steroid has a role in multiple sclerosis, but there is a no role in GBS, right? So this is again high yield stuff. On CSF, there is an increased protein with normal cell count. This is known as albuminocytologic dissociation because the protein is increasing, but the number of the cell is not increasing. So this term sometime you found in your questions, albuminocytologic dissociation, right? Okay. So what about the tendon reflexes? So in this case, the reflexes are depressed or decreased because the peripheral nerves are damaged, right? So reflexes are
damaged.
okay. And what about the reflexes in the likely reflexes in the MS is increased? So hyperreflexia, it's typically maybe the presentation will be upper motor neuron lesion in multiple sclerosis. You know that in upper motor neuron lesion, there is a hyperreflexia. So the reflexes are increased. But in lower motor neuron lesion, that is a typical in the that place in the GBS. So there is a hyporeflexia, a decreased deep tendon reflexes. right? So deep tendon reflexes are decreased. So the, the death, usual cause of death is respiratory failure due to the involvement of diaphragm. Which is a nerve of the diaphragm is
Phrenic nerve.
phrenic nerve. So again, the process is the demyelination. So this demyelination may lead to the respiratory failure due to the involvement of the diaphragm. So the critical respiratory support is a critical for this patient, GBS, because the usual cause of that is respiratory failure, right? So facial paralysis also takes place. The typically facial paralysis in the GBS is a bilateral. Okay, so the role of the thing that in the treatment of the GBS are plasmapheresis. So these are again important stuff. Plasmapheresis and plasmapheresis and IV immunoglobulins. But the key home message, there is no role of the steroid in GBS. No role of steroid in GBS, right? So this is some high yield review of GBS. So the association is with Campylobacter jejuni and some viruses, Zika viruses, right?
Can you repeat that point, please?
So high yield association of the GBS with Campylobacter jejuni. Campylobacter jejuni. That's typically
Yes.
preceding diarrhea. You may found these kind of stuff in your exam questions, in Q banks, in assessment questions. So, right?
Yes.
Okay. So moving towards the amyotrophic lateral sclerosis. Amyotrophic lateral sclerosis. Okay. Amyolateral sclerosis is basically the combination of the upper motor neuron plus lower motor neuron. It is also known as a motor neuron disease. Motor neuron disease in UK. In USA, it is also called some fancy name. Can anybody tell? Lou Gehrig disease. In America, it is also known as a Lou Gehrig disease. But in United Kingdom, it is also known as a motor neuron disease. Why it is a motor neuron disease? There is no sensory involvement. There is no sensory involvement in amyotrophic lateral sclerosis, right?
Okay.
The typical presentation, the typical patient presentation of amyotrophic lateral sclerosis, it is the patient, let's suppose this is a patient, this is the right arm, and this is the left arm. So on the right arm, there is an increased deep tendon reflexes, right? While on lower arm, there is decreased deep tendon reflexes. So the right arm has a upper motor neuron lesion, while the left arm is lower motor neuron lesion. So in the tone of the left arm will be decreased because, and while in the tone of the right arm, it is increased, right? So you have to identify these stuff. And the atrophy and the fasciculation is also present on the left arm, right? So you have to note it that the lower and upper motor neuron kind of thing in GBS. So what about the treatment? The treatment of ALS is supportive measures and about the patient education. So some researchers say that the pathophysiology of the ALS, there is excessive glutamate. So some drugs like riluzole, drug name riluzole, will decrease the glutamate activity. right? So on investigation, you may found on the EMG and nerve conduction studies. So they some sort of again the denervation, demyelinating kind of stuff, right? And the CTMRF, MRI also useful to exclude other pathologies. Okay, so this is some review. Now I'm going towards some vignettes. I made some vignette for you guys. So just give me a 1 minute. I'm changing the slide and opening the vignette, and you have to identify the patient is suffer from the which disorder. Are you ready? Are you ready? Okay. Okay. Can anybody read the first vignette? We have only 7 minutes, and we have to complete these 3 to 4 vignettes. Can anybody read this first vignette for me? A 50-year-old man. Hello. Hello.
Yes. Hello.
Hello. Doctor, please, we have short of time. Please read this vignette for everyone. The 50-year-old man is admitted to the hospital.
I can't see anything. I can't see
But
anything.
wait. There's no
Where's
vignette.
it?
There is no vignette.
No. We
Oh,
see just the screen with MS, GBS, ALS.
Just wait a minute. Just wait a minute. I'm trying again. So now not vignette is visible.
Okay, now it's there.
Okay, please read loudly.
Okay. 50-year-old man is admitted to the hospital with rapidly progressive weakness in his legs, which began as numbness and tingling in his toes. Over the past 3 days, the weakness has ascended to involve his arms, and he is now experiencing difficulty lifting objects and shortness of breath. 2 weeks prior, he had an episode of gastroenteritis. On examination, he has symmetrical flaccid paralysis, areflexia, and mild facial weakness. Lumbar puncture shows elevated proteins with normal cell count. Question 1. What is the most likely diagnosis? 2. What initial diagnostic tests are recommended? 3. What is the primary management strategy for this condition?
Okay, so first you have to identify the which this disorder the patient suffer from. So the gastroenteritis is caused by which bug?
Campylobacter?
This is eating Campylobacter jejuni, right? So the
Yes.
symmetric flaccid paralysis. So the typical areflexia, typical lower motor neuron thing, and symmetrical mean where the if the hands on the right side involved, the hands on the left side are equally involved. This is a symmetric, right?
Yes.
And he have experienced difficulty lifting object and shortness of breath. Shortness of breath, we already discussed about the involvement of the diaphragm. So what will be the diagnosis in this case?
Guillain-Barré.
GBS. So it is a GBS. So you rightly diagnosis this is a GBS. What are the diagnostic tests? Initial. So EMG and CSF. So CSF you find albuminocytological dissociation, and on EMG you find decreased nerve conduction, right? Because of demyelination. What is the primary management strategy for this condition? So, so you use for the plasmapheresis and IV immunoglobulin, and then no role of the steroid, no role of the steroid in this condition, right? Does anybody has understand this vignette? Okay, let's move
Okay,
to the
yes.
next vignette. Let's move to the next vignette.
Now, can you blow up the screen, please, to increase the prints?
Right?
Okay.
Please read. Please read.
Okay. A 28-year-old woman presents to the neurology clinic with episodes of double vision, difficulty with coordination, and urinary urgency over the past year. She describes transient episodes of numbness and tingling in her right arm and leg that lasted for several weeks before partially improving. Recently, she has noticed increased fatigue and muscle stiffness. On examination, she has internuclear ophthalmoplegia, decreased strength in her right leg, hyperreflexia, and a positive limit sign. MRI of the brain shows multiple hyperintense lesions on T2 weighted images,
Okay.
particularly in the periventricular white matter and corpus callosum.
Okay, so the imaging also suggests that the patient has a pair of ventricle white plaques, and the typical is the presentation is upper motor neuron lesion, right? And the high yields of they give the intranuclear ophthalmoplegia, right? So limit sign, which is again the suggestive for the which disorder is
MS?
MS. So what is the most likely
MS.
diagnosis is MS, and what is the initial? It's again MRI.
Yes.
So it MRI and the CSF, MRI and the CSF, right?
Yes, sir.
So
Okay.
MRI is a gold
Yes.
standard. And what is the primary management for this disease? So acute exacerbation, you give them steroid, and
Steroids.
while to prevent the further attacks, you give the interferon, some sort of interferon, other give netluzumab, immunosuppressant, lot of things, right?
Okay, can we be a little more specific on that one for the interferon? Because if they just ask us in terms of interferon, is it going to be alpha or gamma?
It's a beta interferon.
Beta.
Okay, beta. Okay, yes.
Okay, so this is the last minute. So this is a typical presentation. I will summarize for you this one. So this